Okay guys, hang in there. Last one, last PowerPoint of the entire unit. Hopefully we can make it through this one and then breathe a sigh of relief and then just start doing your review. So this one is going to be about lung volumes and capacities, just kind of defining them and going through a couple of the measurements that we will do commonly as therapists. So under this heading of spirometry, there's a couple different things that we're going to talk about. It's basically just a generic term that we use to describe volume and flow measuring devices. So a spirometer is going to measure volume, a pneumotachometer is going to measure flow. There's a lot of different reasons that we want to measure someone's lung volume or measure someone's flow of air in and out of their lungs, and a lot of it is going to be with diagnosing disease processes. So detecting whether or not they have pulmonary disease, classifying it as an obstructive disease or a restrictive disease, or potentially having both, trying to quantify if they have mild disease, moderate disease, or severe disease. And this is all going to help kind of treat that patient, come up with a care plan for that patient, recommend medications that might help the quality of life with that patient. It's also used to determine if a patient will have a high risk of pulmonary complications if they have a surgery. And it also can be used to determine therapeutic effectiveness. So one thing that commonly is done in the pulmonary clinic is they will do a series of breathing measurements to not only look at volumes but also flows. And then they will administer a bronchodilator like albuterol, for example. Wait a certain period of time and then do all of the same measurements again, and they'll see if there is a difference between the two, and the difference has to be, I believe, 20% better, and then they consider that a therapeutic response. And the reason that that's valuable information is if you're somebody who's having, let's say, asthma attacks and they want to figure out a way to treat that, they can give you this medication and see if it's effective in helping you. And with some people, they don't have a response to that bronchodilator, so then that helps them to kind of go down a different route of medication. So the lung volumes that you guys are going to be responsible for memorizing. First of all, this graph over here with the boxes, you are responsible for memorizing that. I'm just going to say that now. I think you see it in survey, but right now you are going to have to memorize it. This up here, you do not need to memorize. It's kind of attached to this because it shows the tidal volume in and out, and it shows the maximum inhalation, maximum exhalation, coming back up to the tidal volume back up and down. And kind of what this is a different visual of this, but this has to be memorized for the exam. So your tidal volume, abbreviated VT, is the total, like the volume that's inhaled and exhaled during quiet breathing. And quiet breathing is just that relaxed, they call it actually tidal breathing. Relaxed breathing, you're not running, you're not exercising, this is just kind of your basic volume of air that's going in and out. Your inspiratory reserve volume, or IRV, is the maximum volume of air that can be inhaled after a normal quiet inspiration. So what that means, because it's kind of a goofy way of writing it, is if you breathe in comfortably, right? Take a breath in, and then you continue to pull that air in all the way up until you can't take any more in. That's your inspiratory reserve volume. Your expiratory reserve volume, or ERV, is the total volume of gas that can be exhaled from the lung after quiet exhalation. So kind of think of that as the reverse. So you exhale normally, just like your normal breath out, and then you force yourself to keep breathing out until you can't breathe any more out. That is considered your expiratory reserve volume. Your residual volume, or RV, is the volume of gas that remains in your lungs after complete exhalation. Now this kind of ties back into the previous PowerPoint where we talked about PEEP. So residual volume is always in your lungs. You can exhale until you pass out, and this residual volume is always going to stay in your lungs. Okay, this is the volume of air that stays in your alveoli all the time. And that volume of gas is going to exert a pressure. That pressure is called PEEP, or positive end expiratory pressure. Okay, so the residual volume is technically the volume of gas. The PEEP is the pressure that gas exerts. And we talked about why that's important, because you don't ever want your alveoli to collapse all the way down. If your alveoli collapse all the way down, then it's going to be very difficult to open them back up again. And there's a couple of reasons that we talked about. Surface tension is one of the reasons that we like to keep a little bit of air in our alveoli, and we want to keep that PEEP or that pressure there, because the surface tension is that propensity of those water molecules to want to bind together closely. And when they do that, they pull that alveolar sac in with them. If you have a little bit of gas in there, or your residual volume, then what that does is it kind of stents open that alveolar sac. It keeps those molecules kind of split apart, and it reduces that surface tension. It also helps to minimize the elastance or the recoil of that alveoli if it's stented open. And really the best way to think about that is, if you go to blow up a balloon and you have no air in that balloon, it's very difficult. It takes a lot of pressure. You really have to push hard with your breath to try to get that balloon to open up. Once you get a little bit of air into that balloon, it's much easier to keep filling it up. You can really just absolutely think about it the same way. Your residual volume, or your PEEP, is that air that's always in your lungs, and you can think about it like having a little bit of air in a balloon and how much easier that gets to inflate. Your capacities, the lung capacities that you guys have to know, are just made up of the individual lung volumes that we just defined. So a capacity is having more than one volume in it. So your total lung capacity is the amount of gas in your lungs after maximum inspiration. So taking in the biggest breath of air that you can, it's going to be the sum of your inspiratory reserve volume, your tidal volume, your expiratory reserve volume, and your residual volume. It's going to be all of the volumes in your lungs are your total lung capacity. It's absolutely the most that your lung can hold. Your inspiratory capacity is the maximum amount of air that can be inhaled from resting and expiratory level, or FRC, which we'll define here in a second. But basically your inspiratory capacity are your tidal volume and your inspiratory reserve volume. I feel like the wording on these is just a little obnoxious when you think about how many of them say the maximum amount of air after inhalation. So what I would do is really learn the definitions of the volumes, and then for the capacities, just know that the total lung capacity is all of these, and the inspiratory capacity is these two things together. I think that's an easier way to learn it, because I just feel like otherwise it gets a little repetitive and it gets hard to distinguish one from a different one. Your functional residual capacity, or your FRC, I feel like I hear this one very commonly. Like, I think this comes up a little bit more, and that's the total amount of gas left in the lungs after a resting exhalation. And this is going to be the sum of your ERV and your RV. And again, what I would kind of draw your attention to is this definition is really not very different than the ERV definition, right? What makes this different is because it's a capacity. It has one more than one volume in it. So this is going to be the ERV and the RV. So your residual volume is going to be included in this. So the definition is very similar to the ERV, but knowing that it is the sum of both of those that makes it the capacity, I think is a helpful way of like kind of differentiating those. Your vital capacity, which is a measurement we use a ton in clinical practice and in the hospital, is the total amount of gas that can be exhaled after maximum inspiration. So this is kind of a unique definition. It's different than the other ones. So what this is if you take the biggest breath in that you can and you blow it all the way out until you can't blow anything out anymore. That is your vital capacity. We use this as a way to determine a lot of different things. I'm gonna leave it there, but just know that this is an important measurement. I don't want to go too far ahead of where we are learning. Just know that this one comes up a lot. This is the sum of the IRV, the tidal volume, and the ERV. Vital capacity, and this definition is kind of unique to this capacity. It doesn't overlap with the others as much. So just think total amount of gas that can be exhaled after maximum inspiration. So if you took the biggest breath in that you could and you blew it all the way out till you had nothing left to give, that is your vital capacity. This kind of shows what those volumes look like in your alveolar kind of anatomy. And I found this helpful when I was a student, having like this kind of diagram, because it shows that if you exhaled all the way down, this is like what your residual volume would be. Like that's how much your alveoli would collapse down, and it would have just this tiny little amount of volume in it, stenting it open. This is if you exhaled down to your ERV, right? So if you didn't do a maximum exhalation, you just did a normal exhalation, then you would still have this expiratory reserve volume here. So that stents your alveoli open even more. This is kind of your tidal volume, okay? So your normal exhalation brings you down to this point. And then this is your inspiratory reserve volume. Like if you took the biggest breath in that you possibly could take, this is how much you're going to expand that alveoli. And then this just shows the vital capacity and how it includes this, this, and this. So you don't have to memorize this diagram. I'm not going to test you on it. It's just another kind of tool to help you visualize the different volumes and capacities that we're talking about. So switching gears a little bit into pulmonary mechanics, we talked about spirometry being kind of like a general term for measuring volumes and measuring flows. So some of the ones that I want you guys to learn about, we're going to talk about in this PowerPoint. I'm going to try to keep it to just a few, and that way you can know them really well. So tidal volume shouldn't be a new concept to you guys. It's abbreviated either TV or VT. If you're not given a tidal volume in a patient case scenario, and that's not as much an issue right now, the default number is 500. So if you have no idea what somebody's tidal volume is, we always kind of use 500 as a default number. Respiratory rate, that's just the frequency of breaths per minute. The normal is 12 to 20. Minute volume or minute ventilation, they mean the same thing, is MV or V lowercase e is going to be your tidal volume times your respiratory rate, okay? And that is going to be your minute volume or your minute ventilation, same thing, okay? Tidal volume times respiratory rate. We're going to talk about your vital capacity and what the normal values are for that. Maximal inspiratory and expiratory pressures we're going to talk about, and then peak expiratory flow. So I just want to refresh you guys. I know in survey you practice doing the predicted body weight. So this might look different than how Kathy teaches it. I think Kathy teaches a different way to get kind of the same answer. This is how I know it, and this is how I teach it. If you have a way that you get predicted body weight that you feel comfortable with, that you like to use, do not feel like you have to use my method. There's more than one way to get there. This is just the way that I do it. The big takeaways for this is if you have a male patient, you're going to start at 50 kilograms for the 5-foot marker. And if you have a female patient, you're going to start at 45 kilograms for the 5-foot marker. Then for every inch above 5 feet, you multiply it by 2.3. So for example, if you have a male patient that is 5'8", I take 8 inches because there's 8 inches above the 5-foot mark. I multiply it by 2.3 and I get 18.4 kilograms. I then take the sum of 50 plus 18.4. This patient's predicted body weight is 68.4 kilograms. From the next patient, you still do the same thing in the sense that every inch above 5 feet gets multiplied by 2.3. For this one, your patient is a female patient that is 5'1". So you're going to do 1, because that's 1 inch above 5 foot, times 2.3 equals 2.3 kilograms. Your base number is smaller because it's a female, so it's 45 instead of 50. You're going to add that to the 2.3, and you should get 48.3 kilograms. The reason that we use predicted body weight instead of actual weight is because the size of your lungs is not determined by how heavy you are. The size of your lungs is determined by how tall you are, as well as your sex, so if you're male or female. So the predicted body weight is a tool that we use to figure out normals or ideal values for lung volumes measurements, settings for your ventilator, baseline function. So if you know the size of someone's lung based on their height, it allows you to calculate what their volume should be for something. So it helps you to determine how far off of baseline a patient is. And I'm going to show you a couple ways that we're going to apply this. So circling back here to minute ventilation, you're going to look at the total volume moving in and out of lungs per minute. The math, and I know this is review, so I'm going to keep this quick. I know you guys did this in survey. It's just tidal volume times respiratory rate. The significance of minute ventilation is that it's normally driven by CO2 production. All right, so we talked about how your ventilation is just to meet your body's metabolic needs or your metabolic rate. If you're producing more CO2 because you're running or you're exercising or you're anxious or adrenaline is kicking in and you're fearful, there's a lot of reasons that you can work up a higher metabolic rate or more CO2 production, but that is what's going to signal things in your brain to increase your minute ventilation or increase how often you're breathing. And so if you think about, if we'll use running for example, when you're running, your tidal volume or the size of your breath usually gets larger, right? You're bringing in more air. You go from a quiet breathing that you can't even notice to almost like a panting breathing. Your respiratory rate goes from a comfortable rate that you don't even really pay attention to a rate that is probably 25 to 30 breaths per minute. And this is because your CO2 is increasing, because when you're running, you're using muscles and you're using a lot of different muscle groups. And as you're using those muscles, they're consuming the oxygen that you're bringing in and they're giving off CO2 as a byproduct. And that's going to create signals that we're going to learn about in more detail that signal your brain to breathe deeper and breathe faster so that it can keep up with the metabolic rate or keep meeting your metabolic needs. Tidal volume definition is inhaled and exhaled during quiet breathing. The normal value, and I want to draw your attention to this range here because you are going to memorize this. The normal value is 6 to 8 milliliters per kilogram. And this is using predicted body weight, not actual weight. So how does this get applied? If you have a predicted body weight of 65 kilograms, the way that you figure this range out is you would take 65 kilograms times 6, which is the low end of that range, and that's going to give you 390 mils. And you would take the same 65 kilograms times 8, which is the high end of that range, and you would get 520 milliliters. So what this is telling you is for a patient who has a predicted body weight of 65 kilograms, their tidal volume range, the normal range for their tidal volume is 390 mils to 520 mils. Okay, and that's how we use our predicted body weight to calculate these kinds of things, and that's how we apply it. So minute ventilation, I feel like sometimes gets tricky. I'm not really sure why, but I feel like sometimes it does. So I wanted to show another version of minute ventilation or minute volume. Again, it's just tidal volume times respiratory rate. So if your tidal volume is 500 and your respiratory rate is 20, this literally shows you each breath that you would take in that minute. And cumulatively, what is that? So 500 times 20 is going to be 10,000 milliliters or 10 liters. This is a good time too to kind of remind you guys, if you have a tough time with your unit conversion, going from milliliters to liters and liters to milliliters, definitely practice that, because that gets a little bit confusing if you're not understanding how to do that. So if you're at all fuzzy on going from milliliters to liters, brush up on it. If you feel like you don't understand it, email me. We can definitely set up more practice for that. That is not a problem at all. Okay, so here are some practice problems that I want you guys to work through, and I will post a key for these, but see if you can try to figure these out, and then I'll post a key and you can compare your answers to the key. Okay, circling back to vital capacity. So vital capacity is the total amount of gas that can be exhaled after maximum inspiration. And all that really means is if you take a huge breath in, as big as you can, and then you blow out till you can't blow out anymore, that is your vital capacity. The volumes that make up your vital capacity are your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. A normal vital capacity is 50 to 70 mils per kilogram. So that's going to be kind of the same version as when you figured out your tidal volume range. You would use your predicted body weight, you would multiply it by 50 for the low end of the range, and then you would multiply it by 70 for the high end of the range. The minimum acceptable vital capacity. This one you guys should absolutely have memorized, but this one really, if you don't remember anything else from this slide, this one's a good one to know. The minimum acceptable vital capacity is 10 to 15 milliliters per kilogram. And what this is the lowest acceptable range that your patient can get, probably before we're going to intubate them and offer a decent amount of support. Because this is bare minimum numbers they should be getting. So this gives you an example of how to do the predicted body weight, and you can predict your vital capacity, the 50 to 70, and then the minimum, the 10 to 15. I will post a key for this, but I want you guys to try to do it on your own and see if you're understanding how this works. Inspiratory force. So there's something called a NIF or a MIP. And just because respiratory has to be this way, there's always more than one name for things. So NIF stands for negative inspiratory force. And then this is mean inspiratory pressure. I think the NIF is used more commonly, but they do mean the same thing. They're a measure of the same thing. The normal value, and these are negative numbers, the normal value is negative 80 to negative 100. The minimum acceptable, which is a number that I would really lock in on because this is one that's used a lot too, is negative 20. Kind of how we use this, because the negative inspiratory force is a measure of your inspiratory muscle strength. If you can't essentially pull back at least negative 20 centimeters of water pressure, then your inspiratory muscles are very weak. That is what that is telling us. So the reason that this is negative, and this is hard, kind of a hard version of not being face to face, is if you can imagine having a measuring device that you put in someone's mouth and they have to suck back as hard as they can, and that measures the strength with which they can do that. If you can't at least get negative 20 centimeters of water pressure, then it means that your inspiratory muscles are so very weak that you could potentially not be able to take in a breath big enough to support your basic ventilation. This would be a patient that we would be very concerned about and more than likely intubate or support in some other way, BiPAP, maybe CPAP, but we would be very concerned that their inspiratory muscles were failing if they couldn't at least get a negative 20. And the reason it's a negative number is because you're sucking in or pulling back. It's measured that way. So this is another really big measurement that we use, that vital capacity and NIF, two pretty frequently used measurements that are very good to know for clinical practice as well as obviously for exams, and knowing what they're measuring and why we care about them. Peak expiratory flow. This is something that we used to use a lot in the emergency room, and we are not using it as much anymore. It's still a relevant measurement. It gets used quite a bit in a clinical setting, but less and less in a hospital setting. But your peak expiratory flow is essentially having someone, this is the device with the mouthpiece, they blow as hard as they can, and it gives us their maximum expiratory flow rate, and it's in liters per second. And what we're doing is we're measuring airway resistance, or we're trying to see if there's a lot of airway narrowing. And if you kind of circle back to the PowerPoint 10B where we talk about airway resistance, we talk about that as change in pressure over flow, and the flow is in liters per second. So this is a device that measures how quickly their flow comes out. And if it's in the green, that means it's normal. If it's in the yellow, it's moderately blocked, or you have like a moderate airway resistance. And if it's in the red, we're pretty concerned. At this point, your flow is really being obstructed. And anytime you're obstructing gas flow, you're basically obstructing someone's ability to breathe. You're blocking someone's ability to breathe. Where you see this used is asthmatic patients. A lot of times will have a version of this at home, and they can blow into it and kind of see where they are in severity if they're having an asthma attack. And that can be beneficial because they can see if it's in the yellow, potentially they can stay at home and treat it and continue to use, like if they have an inhaler at home or if they have a nebulizer at home, then this patient might stay at home and treat it themselves and kind of hope to get into the green. If they start to get into this red and they have a very severe obstruction or a really bad impedance of gas flow, this might be a situation where they would choose to come into the emergency room. So that is the big shebang for that. These are your lecture questions, and I apologize for the delay on those. I did not mean to post the one previous to these questions. I put a little star here that just says know all the definitions of lung volumes and capacities for exam 1. I just want to draw your attention to that. The rest are questions that you can kind of find in the PowerPoint, circling to the more important kind of things that I wanted you guys to take away. Again, I'm going to remind you, if it makes it onto a lecture question, definitely make it a flashcard. Definitely make sure it's something you understand. It's going to probably show up on your exam. If you guys have any questions, as always, feel free to email me anytime.